Thanks, y'all. Appreciate you being here. No microphone, so give me a signal or tell me to amp it up if I need to talk louder. Great to be here, and a real honor. It was, I think, a little tough to follow Nurse Murdoch with her incredible speech. And I'm just here to talk about foot and ankle surgery. I'm Tom McDonald. I'm an orthopedic foot and ankle surgeon. I work out of Hartford. I work for a private practice group in Hartford and within Hartford Healthcare. And I really am proud and privileged to work within these organizations that focus on the culture of teamwork. And it struck me as I looked at our itinerary and curriculum today that that's really what this conference is all about, and that kind of resonates with me personally. So I'm again proud and privileged to be here. I work at this institution, and in one of the hallways is this sign on the hallway that says "Mobility is medicine." And it's kind of my favorite place to be at work because every time I walk through that door, it again kind of resonates with me. And I see this all the time, that what we do together as a team in the perioperative space. For us it could be a Tuesday, but for these patients, I see them downstream of these events, and what we do together as a team makes a huge impact in their ability to be mobile, and it directly affects their health. And it's the best part of my job to see a patient 6 months after we swarm around them, and these are radically transformed human beings, and it really is a powerful experience. And I consider it a great privilege to be on these teams of people that create that change in our patients. So the curriculum is really all about building these frameworks that enable strong and capable teams, right? Workplace violence and inclusivity, and these are foundational topics for us to focus on as we talk about what it means to be a strong team in healthcare. And I congratulate you all for being here on a Saturday and taking time away from your personal space. And this is work, right? And as we kind of strive for success in our profession and in our workplace, it requires this type of effort and reflection, and really, safety, which we're all focused on in healthcare, requires these systems, right? It's not just one thing. It's it's all the personalities in this room, and it's of course the stuff that comes with system development, right? It's paperwork and protocols and standardizations, and it can seem at times when we're in the flow of things on any given Tuesday like extra work and extra time and extra hassle. And I've got 3 daughters, and my 18-year-old is constantly telling me, "Dad, that's a little extra." And sometimes I feel that it usually comes with an eye roll at home, and sometimes I see those eye rolls at work, and am guilty of that myself sometimes. But when I think about it, at the end of the day, I kind of equate what we do in system building and healthcare to flying a plane, right? And at the end of the day, who would you rather fly with? I might be personally inclined to be shaded a little more towards the guy on the right, and that's certainly who I want to drink a beer with at the end of the day. But if I'm responsible for taking care of patients, I want to be on the left with a team of people that have really spent the time and invested the work in creating safe systems. So again, proud to be here, and I just wanted to open up a little bit with that. I'm really here to talk about feet, and this is maybe for some not the most exciting topic. This is the classic summer toe deformity, some are here, some are there. And my specialty, I think there's a bias. We were talking about bias earlier. There's a bias maybe against foot and ankle as an orthopedic subspecialty. It's certainly not as sexy as spine or joint arthroplasty. And when people think about foot, they think about maybe this or maybe a diabetic foot infection. And people ask me all the time, you spent 14 years of training, why did you pick foot? And I think in addition to that maybe visual discomfort that it causes, it also is a little confusing, a little mysterious. I mean, how many of y'all in here have read an orthopedic foot and ankle consent form? It's like a paragraph long. It's got 5 different things, and got all this vague terminology. I'm convinced that no one really knows what we're doing down there. You know, when I'm operating, like people are coming in for the third anesthesia shift change and like, you know, what's he doing down there? And I'm sure he's been there for 2 hours. He's taking like 50 x-rays, and consent form says, yeah, you know, navicular cuneiform, these words we can, you know, hardly spell, let alone say. So it's a little mysterious, and it's multifocal and a little confusing. But why I find foot and ankle surgery to be interesting is just that, you know, we need these things, right? And so although some of the verbiage may be a little uncertain or less than completely clear, the deformities many times are self-explanatory. And so the consent form for this patient would be, we're going to turn his flipper into a foot. And it would take, you know, 18 different things on the consent form to explain what we're doing there. But, you know, this is dramatic. You know, again, mobility is medicine, and most of us can't walk on our hands. So that's what draws a lot of foot and ankle surgeons to this space. And it's more than just bunions and hammer toes. And those of us who enjoy being in this space will, you know, frequently talk about how much we get to do, the bandwidth of pathology that we see, and the patients, you know, attached to them is really diverse, and we get to use all the different skill sets that we learn in our training, from sports reconstruction and the ankle sprain that won't get better, to joint replacement, to trying to eliminate severe arthritic pain and correct deformity, and post-stroke, post-spinal cord injury, the neurologic imbalances that can come from that. So that's what excites me about foot and ankle surgery. And, you know, I think that if deformity and diversity don't excite you, maybe you're in the wrong place, like this Norman Rockwell painting. But what I hope to just kind of touch on today is the progress and evolution within foot and ankle surgery. And I think maybe that's exciting. And certainly minimally invasive foot and ankle surgery is new and hot in my specialty. I was at a national meeting recently, and, you know, literally 6 out of 10 topics were all about minimally invasive technique and the evolution that's happening in my space. So I just want to kind of go through that in a case-based format, just to kind of keep it interesting. My goal is not to bore you or gross you out as I talk about feet. I just want to give an overview of some of the concepts associated with minimally invasive reconstruction, and kind of focus on 3 areas in my specialty that this minimally invasive evolution has touched on and transformed, and that would be forefoot surgery, trauma surgery in the world of fracture and soft tissue reconstruction, and then some deformity correction. So, you know, everything about minimally invasive foot and ankle surgery is a little different, and I want to go through some of those differences and then just highlight, you know, some of the advantages. When we talk about minimally invasive, we're talking about, you know, doing the same things we've always done through smaller incisions, and that sounds like a good goal to be maybe cosmetically pleasing, but more important, you know, what you're creating is a surgery that has less dissection, less disruption of the blood supply, and with that comes, you know, less pain, less swelling. Instead of taking a joint apart and putting it back together, we're working next to the joint, and that allows for less joint stiffness post-operatively. And we think what research is starting to show is that patients are healing more quickly. They're getting back on their foot and back to their activities more quickly. And that's exciting. Again, mobility is medicine. So, you know, just to talk a little bit about how we set this up in the operating room and try to do these things a little differently. For a lot of these cases, the foot is hanging off the end of the bed. These are heavily X-ray dependent procedures. We're using mini C-arm and fluoroscopy. Many times you can take the well leg and prop it up on a popliteal leg rest, or use an extra arm board and get it out of the way. We talk about a lot of these cases, because of the small incisions, being done with no tourniquet or with an Esmark tourniquet. And really the whole key to success, if you're trying to fix a foot through minimally invasive technique, is getting things positioned in such a way where you can get your C-arm easily manipulated so that you can see what you're doing. There's two pedals, and my team is constantly moving pedals and kicking pedals over to me, and I'm kicking them out of the way. And it's a little bit of a foot and ankle shuffle as we negotiate the power for the burr, which we'll talk about, and then the fluoro pedal. So this is kind of what it looks like. as we're positioning the patient and getting everything shuffled around. And this is, really the magic of minimally invasive foot and ankle surgery. This is what makes it happen. If I had an Al Pacino or Scarface slide here, it would be, this is my little friend. These burrs come in different shapes and sizes. They're different diameters and lengths, and they allow us to get to the bone and do an osteotomy, cut the bone through a small incision. These are hooked up to a handpiece and hooked up to a kind of a TPS box. And the magic of this is that there's a little reducer that enables the burr to spin at a lower RPM. So for context, a classic high-speed burr would spin at about 25,000 RPMs, and this cuts that down by about a quarter, down to about 5,000–6,000 RPMs of the typical revolution speed. And what that does is it allows you to cut bone with less heat. And so we worry about thermal necrosis and burning bone. And so this high torque, low speed burr is kind of like, if you're a car person, kind of a diesel engine. It's kind of geared down and allows you to do to generate less heat as you're cutting bone. So this is where the technology has developed that allows us to do foot and ankle procedures in a minimally invasive way. So, each one of these topics, these cases, could be a talk in and of itself. I'm not really here to talk about bunion surgery per se, but let's just kind of go through what a minimally invasive bunion surgery looks like. This is where kind of the revolution or evolution in foot and ankle surgery started. How can we fix bunions through a minimally invasive technique? And then it's kind of expanded into other aspects of what we do. So this is called a transverse first metatarsal osteotomy. That's what the consent form would read, but what this is fixing a bunion. A bunion, of course, is an angle between your metatarsal bone and your toe bone. And it's not a bump, right? It's an angle. And so I'm always explaining to patients in the office that we're not really shaving the bunion, we're shifting the bunion. And in order to do that, we cut the bone. So as you talk to patients about minimally invasive technique, they say that sounds great, but if you really kind of break it down and make sure patients understand what we're doing, we're doing the same thing we've always done. Opening up the hood, we're cutting the bone, we're shifting it over, we're holding the bone into its new position with screws. It just looks a little different now because of the smaller incision on the outside, and then the shift in the hardware that we use is a little different than typical technique. I'll show you that. So this is a picture of just making a small incision and holding that burr like a pencil, and using a lot of fluoro to make sure that you're cutting the bone exactly how you think you're cutting it. The amount of fluoro that we use drops as we get more seasoned and experienced with this, but it is an X-ray dependent procedure. I'll skip the video here, but as you cut the bone, then you can use any number of instruments. There's different ways to take the capital fragment, the head of the metatarsal, and shift it lateral. And you can get a pretty dramatic looking shift. You're kind of moving that metatarsal head, sometimes 100% translated, so that the bump, the width of the forefoot is really narrowed. And then as you cut and shift and translate, you can then make smaller percutaneous incisions and fire these guide wires in so that it secures that fragment in its translated and shifted position. And again, I'll spare you the 5-minute video there, but this is what it looks like in the end. This is a bunion surgery in which the metatarsal head has been shifted and tacked into place. We also often will do this osteotomy on the toe bone, take a little closing wedge, a little piece of pizza out, if you will, a little triangle, and kind of kick that thing over and fire in another screw. So now, as I tell patients, the ice cream is sitting on the cone. The bump has been shifted, not shaved, and that's what a minimally invasive bunion surgery looks like at the end. And so we use this technique not just on bunions, but for a variety of foot and ankle pathologies. And you can use the burr in different ways to cut and lift and shift and reduce pressure points. And the miracle of this, of course, is just the biologic healing that happens over the next 3 months. So just a couple of cases. This is a 68-year-old gentleman with a symptomatic bunion. Bunions can hurt people in different ways, and it's amazing sometimes how this little bump can really affect people's life and their mobility and keep them from doing the things they want to do. So again, a common part of my practice. And this is what it looks like after it's been cut and shifted. And it's a little dramatic. You have to tell people that, you know, they're going to have a crooked x-ray and a straight toe. And what happens, you know, again, the miracle of that is, you know, how could that possibly work or heal? Looks a little funny on x-ray, but if you follow these patients out, biology just remodels and kind of connects, glues and ossifies and calcifies, and these patients are pretty functional pretty early. This is another example of that dramatic shift where you're cutting the bone and shifting it over, and really, you know, doing that through small percutaneous incisions. This is what that looks like on the day of surgery. One of the most frustrating aspects of any bunion surgery, including minimally invasive, is that we stay swollen for a long time. So it takes a lot of patients about 6 or 8 weeks before they can get that pumpkin of a foot back into a shoe. But this is a patient 6 weeks post-op, and they've got great motion, again, minimal scarring, minimal pain. That's, of course, a big worry that a lot of patients have around foot and ankle surgery. That's probably one of the most common questions that patients ask me is how badly is this going to hurt? Because I know someone, or, you know, my aunt had this. She said, don't do it. So it's a dramatic change in what we can offer patients, especially if you know, compare it to the traditional techniques. So this is an open procedure, and there was just a lot of take apart and put back together as we shift bone over, and you can see the difference in incisions between a traditional bunion surgery and a minimally invasive bunion surgery. So that's been a revolutionary change in my practice. And again, the advantages are less pain and less joint stiffness and improved cosmesis. People like the image on the right more than they like the image on the left. And it takes, as you get used to it, it takes a little less time in the OR, and these patients can walk on it right away. And we're starting to see published literature that talks about a lower rate of complication. So, you know, we'll kind of go through a couple other examples, because minimally invasive surgery, although it started with forefoot deformity correction, it's not just for bunions anymore. It applies to ankle fractures and Achilles ruptures. Those are two common traumatic injuries that I'll see as a foot and ankle specialist. And we'll talk about one of them. Probably the most common type of ankle fracture I see is not the dramatic, I fell off a 30-foot ladder, or I was involved in this high-speed injury. It was just I was going to the mailbox. I was checking my mail, or I was, you know, going down to change the laundry, and I missed the last step. And so this kind of common slip and trip fall or ankle fracture will have a displaced fibula fracture, and then it's not just the broken bone that makes this fracture unstable, it's the associated ligament injuries. I'll show you an x-ray in which you can see that there's 2 main ligaments that are torn or disrupted when we break our ankle that make a ankle fracture unstable, and one that we would recommend surgery for. And so here's an x-ray where you can see the fibula fracture, and you know, if it was just that, biology is going to heal that great. That doesn't necessarily need internal fixation, orthopedic surgery, but it's this widening of the clear space that you see here, and you'll take my word for it, there's a little gap between the fibula and the tibia, and that's where your syndesmotic ligament lives and your deltoid ligament. And an unstable ankle fracture will have not just the bony component of the injury, but also this important ligament disruption. So the traditional way to fix that is, again, to open up the hood and put plates and screws on the fibula. And, you know, it kind of looks like this in a cartoon fashion. And you guys have seen all the fancy titanium plates and screws, and many of you have seen open ankle fracture surgery before, which is sometimes still necessary. But if you can avoid that and fix the bone and fix the ligament through a minimally invasive technique, couldn't that be better? And the answer is we think so. And that's starting to evolve in my space. A lot of times when you open up the hood, it looks like a bomb went off. There's already this dramatic soft tissue injury and stripping of the bone, and then we're just, you know, doing more of that as we kind of manipulate and put in our plates and screws. So this evolving approach involves a lot of times ankle arthroscopy, and then different technologies are starting to evolve where we can instrument the fibula, fix the fibula through a minimally invasive technique. So this is an example of what we call a fibular nail, And instead of a plate and screws kind of on the external surface of the bone, this is an instrument or an implant that's going in through through a small incision at the tip of the fibula. And so it looks a little different, just like your minimally invasive forefoot surgery looks a little different on X-ray. But you're trying to achieve the same things that we've always achieved, which is an anatomic reduction of the fibula and closing down that medial space. A lot of times we'll get a stress view before we start the surgery, and you can really see the instability, kind of the medial lateral shift of the ankle. Ankles are pretty good in the up and down plane, but they don't do very well if they're shifty, loosey-goosey, medial to lateral. So we're trying to bring that relationship, that three-sided box, if you will, into a nice tight position. And this is what the incisions look like after a minimally invasive fibular nail fixation. Again, radically different. Small little poke holes. I tell my patients all the time, you're going to look like a pack of squirrels got after you. There's going to be a little bit here, a little bit there. And then this is another example where maybe on the right, if that's projecting, you can see that the fracture line is pretty high. You can see the fibular fracture right there. And if you're going to put a plate and screw on that, you have to make a big incision from the tip of the fibula all the way past the fracture site up the leg. And so these high, we call them Weber C, that's the pattern terminology that we use for describing where the fibula is broken. These high fibular fractures traditionally require a lot of open surgery. There's just a lot of muscle in the leg that you have to elevate and get out of the way. There's an important nerve that goes through here that we're constantly trying to avoid. And if you can instrument and reduce and stabilize the fibula through a small percutaneous incision, this makes a huge difference for patients. We'll go through another case example. This is a more complicated ankle fracture in which maybe I can't get all of those pieces, this fracture dislocation, this trimalleolar, broken in 3 places, joint is dislocated. Maybe I can't cobble all that together through minimally invasive technique. But again, this fibular fracture being one of these high fibular fractures, it's going to require a really long incision on the side of the leg, in addition to the incisions that we're going to make to fix the rest of the joint. Here's a CAT scan that just kind of highlights the bony component of the injury in greater detail. You can see the back of the tibia broken off, this high kind of comminuted fibular fracture. This is an axial view where the patient's laying down and their feet are sticking out at us and going through the ankle in slices, and you can see the back of the tibia is cracked off. And so we'll fix that tibial component through an open medial incision and put a plate on the back of the tibia that kind of nicely reduces that and keeps the ankle joint nice and centered and congruent under the tibia before it wanted to kick out the back because it didn't have this supporting wall, if you will, on the back of the ankle joint. So that's standard open reduction internal fixation of the tibial component. But then if we can add through a series of percutaneously applied clamps, this intramedullary nail fixation to the fibula, we're saving the patient a lot of soft tissue dissection, a lot of scar, and a lot of pain. So this is what that intramedullary nail looks like as it's slid up the fibula, combined with a plate on the back of the tibia. And this is the incisions pattern that we use on the lateral aspect of the ankle. And you can see that if I were going to plate this, I'd have to use this plate to really capture that long oblique fibular fracture and secure it above and below. And that would be a giant incision on the leg. So this is an alternative way to achieve the same outcome with smaller incisions. So I'll shift gears a little bit to Achilles ruptures. You guys are super familiar with this. It's prominent in our headlines, and everyone knows of a story or knows of an athlete that's had this injury. It seems to be occurring more often these days. At least that's the feel you get every athletic season. And so an Achilles tendon rupture, I think I've got this on video. It was kind of a neat thing to see where it's captured at the time of injury. I don't know if there's volume here, but you can kind of see this explosion that happens. This is a high caliber sprinter who's training, and down she goes, and we've seen that on ESPN highlight films. So it really is a dramatic soft tissue explosion. It's pretty easy to diagnose, even if you don't witness it live. Just the history and the physical, people will commonly share the same story. I felt a pop, I felt an explosion, I felt like someone kicked me in the back of the ankle. A lot of people will share that. You can see kind of a palpable gap in the soft tissue. There's weakness. There's a classic orthopedic test called the Thompson test, where you have the patient lie on their stomach and bend their knees up and squeeze their calf, and nothing really happens. And so it's not hard to diagnose. You don't always need an MRI for this, but when we do get an MRI, kind of the findings are pretty classic. The Achilles tendon can rupture high, which is a little less usual, or kind of in the middle, or down low, and you can see this black line. The Achilles tendon just kind of disappears into this bright light up of inflammatory fluid and blood. So that's what it looks like on the MRI. And when I was training, there was really only one way to fix this. We would spend a lot of time learning how to make the strongest, toughest construct of non-absorbable braided suture and weave it through the tendon in different ways, and bring it to the cadaver lab and test it, put it on this cycling machine and see how many newtons we can pull through the repair. And the whole goal and thought process was to make the biggest, baddest, strongest Achilles tendon repair we could. And in order to do that, you have to open up the hood and get to both ends of the ruptured tendon. And for a long time, that's the way we were trained to fix this. And these are all different patients with different Achilles tendon incisions, and a lot of these patients will do well and can do well and can get back to sport, but not everyone does. And sometimes a fallout of this injury and the surgery is the scar and the pain that comes with scars, the adhesion of the skin, nerve sensitivity. These are real issues for some patients who go through Achilles tendon surgery. And so, over the last 10 years, maybe 5 years especially, that modern definition of Achilles tendon surgery is starting to evolve and change. And we're trying to do this through a minimally invasive approach whenever we can. And so there's a variety of implants and technologies that have evolved that allow us to, again, reach the top of the tendon, the bottom of the tendon through a small incision. You can put this little tuning fork device through a small incision and kind of put the tendon in the middle of the tuning fork, and then you pass these percutaneous sutures, and they kind of go through the fork, through the tendon, through the fork, and out the other side. And then you can pull out that little gizmo, and out come the sutures through that small incision. And now you've grabbed that tendon in a way that's different than the way we were all trained to fix it originally as in our surgical training. And so this is another type of device that's out there, where again you're trying to grasp the tendon and pass these sutures percutaneously. And this is the incision, and after it heals, that you end up with through this minimally invasive technique. You can make your incision transverse or longitudinal, but it's a lot less scar and a lot less adhesion and some of the clinical difficulties that come with scar tissue. So I'll switch gears again and just show you a deformity correction case. And this is actually the very first minimally invasive surgery that I did in my practice about 5 years ago. So this is relatively new in my personal career. I've been in practice for 18 years now, and this is new in my specialty, new in my practice. A lot of my teammates who are here in this room would say, yeah, it looks like you're new at it, doctor. It takes you a while. But this is about 5 years ago. A 36-year-old lady who at the age of 21 got tangled up with a lawnmower. And I met her, downstream of this limb salvage reconstruction surgery that she had. You can see that they had to get rid of her big toe. Her second toe is now her big toe. Her whole first metatarsal was missing. They had to fuse all of her midfoot bones into one big continuous stretch of bone here. You can see the vascular clips on her x-ray. You can see the shadow of her soft tissue, and you know that a lot of soft tissue and plastic surgical work was done to address what you can imagine as a horrible mangled injury as they tried to save her foot. And so when she came to me, I had just learned about minimally invasive technique. I'd been to a couple of conferences. I went to a lab and practiced on the cadaver, and was training with a buddy of mine, and was kind of getting ready. Most of us, as we adopt this minimally invasive technique into our practice, we start with something small. We're going to just kind of do a little toe osteotomy or a little hammer toe. And I, was ready to do it the way we normally do it, kind of start small. But this patient showed up, and really, you know, in her condition is not a candidate for traditional open surgery. You can see here that she's walking on the outside of her foot. She can't even get her foot down to the ground. If you go back to this x-ray, I'd ask you to kind of pay attention to the fact that she's walking on the whole fifth metatarsal. The rest of her foot is elevated off the ground, and so she's got this pressure point right at the base of the fifth metatarsal there. And you can see that clinically, she's walking on this spot. She has this kind of horrible chronic vascular dermatitis. Her skin does not look good. You certainly wouldn't want to make an incision there to kind of cut and derotate the foot into a more neutral or plantigrade position. I'd be worried about her flap and worried about, you know, soft tissue healing and possibility of infection. Here she is with that callus on the outside of her foot. This hurts like fire every time she takes a step. This is a little see-through weight-bearing plate that we have pressed against the bottom of the foot on the day of the surgery, and you can see where she's overloading. And her options, you know, she had been told by several surgeons that really she should think about amputation. This is a kind of a non-functional, chronically painful foot. Her pulses were marginal. Her skin was horrible. You could think about revising that, again, taking out all of that hardware and cutting the foot in half, so to speak, and derotating the foot. That's a well-described technique for a problem like this, but she wasn't a great candidate. So I had a long conversation with the patient. I said, you know, I literally just learned how to do this. This is what I think you're a candidate for. There's no guarantees, but I think if you're going to have a surgery and try to save your foot, this is what you should do. You should take a pin and kind of percutaneously put it through the front part of the foot, and another pin and percutaneously put it through the back part of the foot. You make your little incision here and you sneak in your burr, our little friend the burr. We had to take out some of the hardware that was existing there so that we could kind of connect the dots, putting a burr in from medial and a burr in from lateral, and again, creating a midfoot osteotomy, sawing the foot in half. And then I'll show you this little video. You know, that part of the surgery took about 20 minutes, and then I spent the next 20 minutes just kind of playing around with this fascinating derotational power. You can really see what a difference you can make in the way the foot's going to hit the ground. There's another video here that kind of shows that translucent flat plate and being able to kind of take the foot off of the weight-bearing pain point there. So that was eye-opening for me. And this is the incision that was used to take out our hardware, and this is the incision that was used to do the osteotomy. And there's that pack of squirrels again. They kind of got after her as we made these little poke hole incisions to do that. So that was dramatic and life-changing for her, where she was walking on the outside of her foot, and you can see the difference now as her foot's been derotated, and those osteotomies heal very quickly and very well when you're not taking apart the soft tissue and the blood supply. Just another quick example, this is a condition called peritalar subluxation, and again, one of those foot and ankle terms, but you know, you don't have to be an orthopedic foot and ankle surgeon to see that this is not the way it should be. Your three-sided box is kind of falling apart. Your talus is spilling out of its relationship. And you'll take my word for it and know that every joint around this talus is really loosey-goosey. This patient is walking on the inside of their ankle and the inside of their foot. They're having a lot of difficulty. And the classic fix for this is to do what's called a pan-talar fusion. So you take all the bones around the talus bone, the central hinge bone of the ankle, and you stick them all together. And that's a dramatic way to correct the position of the foot and eliminate the pain that comes with that multi-joint instability. But it traditionally is a huge operation. A pan-talar fusion involves a big incision where you're taking apart and getting all the anatomy out of the way so that you can cobble those bones together. And where minimally invasive foot and ankle surgery for me gets really exciting is we can take those bigger surgeries, those limb salvage surgeries, and apply them to the most frail of our patients with the most severe deformities. And so I'll just kind of fly through this study that I was really happy to be involved in. This is a multi-center study in which we kind of collectively gathered 52 patients who had these severe deformities. These were frail, sick patients, and we wanted to look at fusion rate and complication rate as we corrected these deformities through this minimally invasive technique. This is, again, another clinical example of that foot that has slowly become a flipper because of neurologic imbalance. And you can see what the x-rays look like. This is a really rigid, bony deformity where the patient literally can't walk on their foot. And so how do you kind of unwind that through a minimally invasive technique? Again, you use your burr, you use small incisions, and you just start to osteotomize and shave out arthritic joint space. And you can use a camera and see what you're doing on the inside to get rid of cartilage and get fresh bone and fresh bone. You can percutaneously cut the fibula bone and allow those blocks to shift back into a neutral position. And there's some x-ray images of us doing that. You can use what's called closing wedge osteotomy. So again, you're taking wedges or triangles out to allow the bony blocks to shift over. You can correct their flexion deformity, their toes down or equinus deformity by taking preferential wedges out from the front. And then you get everything all kind of lined up and pinned in place, and you put in this implant called a TTC nail. It's like the mother of all fibular nails. This one goes from the calcaneus to the talus to the tibia, and it's a common way common implant that we use to do a pan-talar fusion, but now we're doing it through these percutaneous incisions. So the results of this study, basically, again, looking at some patients who are the sickest of our patients, 50% of these patients had peripheral neuropathy, end-stage renal disease, poorly controlled diabetes, severe peripheral vascular disease. These were sick patients. And traditionally, if you look at open TTC fusion for these patients, there's a high rate of non-union, a high rate of infection and wound healing problems. And in this series, we saw improved fusion rates and decreased risks of infection in a pretty dramatic fashion. So we think we're on to something here. Here again is a lot of orthopedic hardware, TTC nail and screws to align these blocks and stick them together if you use that block analogy. And this is what it looks like. So we can put that amount of orthopedic hardware in through a multiple of percutaneous incisions. We think we're making a difference. So I'll just summarize and say that modern foot and ankle surgery is evolving. We're evolving in our technology. We're evolving in our thinking. We're getting away from kind of the biomechanical strength to failure mindset, and we're thinking about how to be more friendly to biology and preserve some of the blood supply and institute some dynamic rehab protocols. And what we're doing in my space in foot and ankle is what we're all doing professionally, right? We're just asking the question, is there a better way to do it? This is a patient of mine who has the best life mantra tattoo I've ever seen. And we're all asking this question, right? So for me, is minimally invasive foot and ankle surgery better? Does it less? I think the answer is yes. Is it a valid concept? Yes. And we're starting to see some of the advantages that comes with that novel approach. So I'd say thank you and congratulations on being here and being part of a team that makes life better for our patients. Yeah.
Are you doing these under local and are you using X-Braille blocks?
That's a great question. In my surgery center, X-Braille is used probably for bigger procedures, probably less for the minimally invasive. About 95% of our patients will get a peripheral nerve block in addition to either sedation or a MAC anesthetic. And I'll tell my patients that, the first day is going to be great. Night of the surgery is going to be great. The next day when the block wears off, you're going to have pain that's kind of in the middle. That's been my experience as I talk to patients. Most patients are worried it's going to be up to our eyeballs, and instead people are sharing with me that, it really wasn't bad. I took a pain pill the first day or maybe the second day. I was worried about it. Some people have the experience of taking a pain pill and realizing they just didn't need it. And so a lot of patients after these minimally invasive forefoot surgeries are down to Tylenol and Motrin after the first 48 hours. We use a cold therapy machine, which is really impactful for patients. A lot of people really love that.
Like the quote they're like they use for the joint replacement.
Yeah, same thing. There's different wraps that come with that, knees and shoulders and foot. It's kind of a universal wrap, but we kind of work that into the dressing so that when patients get home, they just kind of plug and play, and they get a lot of instruction around that. And I'd say 90% of people tell me that makes a huge difference. Probably even more in my practice than the Expro. Yeah. Thanks. All right, you guys are great. Leah, thanks so much for having me. I appreciate it.